start things off, I think we can all recognize that opiates remain a predominant strategy in chronic pain management because of their accessibility, affordability, and acceptability. What can CBD manufacturers, clinicians, researchers do to help lower these barriers to access and decrease the stigma associated with cannabis treatments? And whoever wants to take that first, please feel free.
I'll jump in there first. One of the things that we're actively doing, so we are just now bringing our CBD line of products out. Previously, we were focused just on THC cannabis products in Oregon. But if you're familiar with the cannabis market in Oregon, we have a massive oversupply problem. And so trying to sell weed has become very difficult in Oregon. So if companies want to succeed, you're looking at ways that you can branch out of that market. So we're bringing CBD lines on, and we've contracted with a pain management physician in North Carolina who's begun to use CBD in his practice and has started some early data gathering. We're about to retool their product lines and also bring on some competing product lines to see the sort of results that we can get. But as we know, in 2015, they looked at a retroactive study, and they looked at the 33 states that allowed cannabis, and what they found was 30% fewer opiate prescriptions, 30% fewer overdose deaths, and a loss of $186 million to the pharmaceutical industry. So the pharma is interested in this too. I think that GW's pharmaceutical is just scratching the surface, but one of the ways that we're starting to bring this to reality is doing clinical trials in pain management practices, putting up CBD products against real opiates, and trying to actually bring some data and some real science to the environment. Large, randomized, controlled sort of trials are the only ways that we're going to start to convince the minds of physicians and other healthcare practitioners that this is a safe and effective alternative.
If I could just chime in on that, the downside of that, though, is, or it's not the downside, but the unfortunate reality is that the people who have the resources to do those large randomized controlled trials are the drug companies, and they don't like us. Right? We are a threat to them. So what we're going to have to be accustomed to is small trials. It's going to be guys like me doing clinical research, or like your guy in North Carolina, or in a pain management clinic, people putting together these studies with the smaller N numbers, it may be 10 or 20 people, and it's going to be conglomeration of these smaller studies that are really going to get that ball rolling. And I think as a community, we have to embrace that fact that those big trials, they're just, they're impossible to fund.
So, I'm just going to clarify one thing. So we're actually not doing an FDA certified trial, but he's treating 20,000 patients. So we're going to be able to actually, all of those won't be used, but we're going to be very specific and at least start to see N numbers of 500, 600, 700 kind of patients, which is important.
It's tremendous. That's huge, man. That's great.
And we're doing it in a cost-controlled environment, because you can't do an FDA-level study, as you said, without millions of dollars. Sorry.
I'd say in removing the stigma, it's educating consumers so that they're asking their doctors for it, and they're educated. Don't think that it's, when they're asking for a hemp CBD product, that they're asking for something that's illegal or that would have a stigma attached to it. We live in the South, in the Bible Belt, and I was certain we were going to have trouble really launching our product in that area because I figured the stigma and I'd get a whole lot of kickback, and we found that we just keep educating people and telling them about it and having them try it, giving them multiple ways to use it, topically, internally, in the food, giving them a variety of different ways to access CBD, and then have their own experience and their own results, is kind of spreading the word organically in our community. And then we offer online communities for our consumers as well, just so they can talk someplace freely about it.
Awesome. And I'd love Dr. Menison to start us off with this next question.
Can I just chime in on the last
Yeah,
thing just a bit?
please.
I think what's important to point out is that with CBD, because it's coming off of a Schedule 1 to a Schedule 5, which is great. Dr. Finkover, he can tell you, I'm sure, on his side. A lot of physicians, and I'm a chiropractor, a lot of people in my field, a lot of pain management, anywhere you're looking, they really aren't that familiar yet with the CBD. And it's very important to note out that a lot of times taking CBD in conjunction with prescription medications, most doctors will not have a problem with that unless there's a cytochrome P450 issue that they're aware of. Usually we look at the grapefruit label. So if something says, oh, like a statin, don't take a medication, with grapefruit, consider CBD in that same realm, so you have to be careful with that. This does not mean it's a complete contraindication, but you need to talk to the physician. The person prescribing really needs to be on top of that, because again, we're not prescribing CBD, and it does get broken down and in the liver. It competes with cytochrome, it binds to cytochrome P450. Physicians want to know what's going on with their patients. If they can identify if they have a patient that is taking medications and they feel CBD will help, or it's not toxic or otherwise dangerous, which we all know pretty much isn't, most physicians will be open to letting a patient try something, because, hey, if it helps them, it's great, and as long as there are no side effects, because they're kind of learning about it through this community as well. So it's very important on that side. So.
Absolutely.
So there's not my main point is there's usually no harm in adding CBD to an already existent medication regimen, provided the physician who's prescribing is in on that, understands it, and gives it an okay. And you'll see it a lot, especially in mental health. There's seems to be no issues with that. So.
Building off that exact point, when we talk about finding the best treatment for patients, this can often mean a combination of techniques and medicines. Do you think, and this is for the whole panel, but if you would like to continue, that cannabis or CBD specifically can be a substitution for opiates, or should we be thinking about it in a different kind of way?
I'll just continue, because that's exactly what I was referring to. Most of the doctors I work in the pain management also will cross over into mental health, because that's a big area that CBD plays in. They don't seem to have a problem with introducing and I'm in Maryland, which is a pretty open state. We have great medical cannabis laws. So most physicians that I work with at least do not have a problem with blending them together. However, if you want to go with your doctor and say, I'm going to stop all my medications for either mental health or for pain management, I'm only going to do CBD, they might look at you a little bit funny and get a little bit upset and say, who told you to do that? So we don't really want to rub people the wrong way with this. Physicians, they're doing the prescriptions on the medical side. They need to be aware if someone's taking CBD. And the argument always comes in, well, what is CBD? Is it a medication? Is it botanical? Is it just a plant-based? I mean, the pharmaceuticals, as Dr. Finks, is talking about the large randomized controlled studies and a placebo. They would love to take CBD and say it's a drug, and we're the only ones who can control it. And probably the way that's going to occur, when I've thought about this a lot, because I do research all the time, and I'm taking a master's in this program in this topic, it's probably going to go through liver detox, meaning someone's going to be taking CBD, they're going to be taking statins or something else, they're going to have a liver problem, which I don't really know, and you can probably know a little bit more on that, probably not have a problem, but if they do, the first thing that people are going to jump on is they're going to say, aha, you're taking CBD, it's bad for your liver, we need to start really banning it and looking at it and let the pharmaceuticals, because they're creating the statins, let them control everything, in which case everything we're doing here goes really for naught. So we have to be very well aware of what people are doing in that regard, and be really aware that probably the only interaction we have to worry about is with the liver. I keep going back to that, but that's probably where we're going to get knocked, if we're going to get knocked on something with CBD. Dr. Ping, do you want to comment on that?
Well stated.
So I'd like to chime in on a few things. Number one, doctors aren't even taught about the endocannabinoid system in medical school yet. So we need to begin to get our health professionals educated on a topic that we know now is a real topic, that we're not witch doctors, we're not snake oil salespeople. So we need to get our healthcare professionals up to date and on current literature. Second, yes, it is a fatty digestible liver kind of product. There are ways to avoid that with water solubles that can be easily absorbed through, the oral mucosa or the skin or, other ways. So I think that he's right, that we have to be careful. As our FDA document that we supplied to Congress, we basically said that we think that you should be breaking CBD into two subgroups as they have in pharmaceuticals many times. So you've got your pharmaceutical grade FDA trial products that can make substantiated evidence-based claims, and then you've got your dietary food additive supplements. We know that through GW Pharmaceuticals study that CBD at 3,000 to 4,000 milligrams a day is safe. So why do we care about 5 or 10 or 15 or 20 or 50 milligrams in a food additive? And so that was what we told the FDA is like, look, you do this with omega-3 fatty oils. So they already have a model for how it could work, and we're hoping we push them in that direction, but I think it takes groups and panels and communities of people all hammering them with the same information so that we can carve out our space, and it's going to require us working together as cannabis and CBD communities, and how do we actually come together to make sure that we can push those regulatory agencies into the direction that we want them to go, because as we know, pharmaceutical lobby is a powerful, powerful lobby in Washington, and we need to be there on the ground doing our thing to be educating our legislators who are going to be writing these policies.
Can I add one thing, and right in line with what he's saying, when he was talking about topicals, for the audience here, when we look at anything that's an edible or oral, okay, and even on the THC side, there are pathways to the liver that it goes to. The liver actually makes the THC more psychoactive, by the way, which is very interesting. So how do we avoid the liver? So James is alluding to, like, topicals are great, but anything that we either smoke, vape, okay, we can smoke it, we can vape it, okay, we can use nano formulations, which are spectacular, or nasal sprays, things like that. I'm getting big into nano myself with the nano scientists. These are things that do not go what's called first pass, which means it's heading through the liver. That's why these mechanisms have much better bioavailability, and it goes directly into the bloodstream where it interacts more with the CB1, CB2, and what else they discover receptors, so we can bypass the liver with those forms of getting CBD into the system. As far as the actual opiate question, which we're kind of circling around, the current guidelines right now is a level 2. The first attack on chronic pain, or the reason why people are taking opiates, it basically is through gabapentin, which is what they're looking at as a first pathway. The second pathway is still tramadol and what they'll call light opiates. The medical community knows very well opiates are very dangerous, but they also work for pain. Now, we've crept up in the world where CBD medical cannabis is now level 3. It's the third tier.
And we're good.
Hey now. Everyone's on handheld, switch up, see if everyone.
Yeah, we'll just pass them around.
See if it works there.
Should I sing? Does that work? Can you guys hear me? You can't hear me?
Yeah, we got it.
I can just yell. Okay. What did I get to? What did you guys hear, not hear? Before everyone's ears broke, or no? Everyone has.
We're talking about the different pathways.
The first pathway. The first attack is going to be through primarily gabapentin, similar drug to that. Second path is going to be your tramadol, your lighter opiates. The third is now, and the second is also going to be topicals and things that you can use like that. They still put capsaicin in that category. They still put, like different types of cream, like lidocaine, different types of creams. Third is is going to be where we sit with the cannabinoids, which is great, whether it be the THC on the medical cannabis, CBD, and then there's still a fourth tier, which I don't even look at, because once it got to us, I'm like, yes, we're moving up in the world. That was really changed in like 2014 or 15. There are Canadian studies on that. That's where the guidelines are coming from on that. That's how chronic pain is being attacked right now. So whereas we were never on the chart before, now we're number 3. The key is how do we leapfrog? How do we get above tramadol and get those opiates really down on it? I think it's a matter of time. I mean, we definitely need the research. But I mean, heck, with all my patients, I've been in practice 20 years. They all love CBD, and I work with their pain management doctors, and they all get great results. And it's changing. It's slow, but it's going to continue to change. So.
Oh, just from the patient's perspective, I think communicating with doctors as you add CBD into your regime and letting them know exactly what your results are. And I have Ehlers-Danlos syndrome. It's a connective tissue disorder, causes lots of pain. So I was on tramadol and Moxicam, is that the prescription? Yeah. And so I communicated with my doctor as when I started taking it, and have communicated along the way. When I first started taking it, she said, it doesn't work. I've had people try it, it doesn't work. And so I was like, well, I'm going to try it, and I'm going to tell you how it works. And so I now don't take anything at all. I don't even take Advil anymore, and use a combination. And what I came back to her with was, I take internals. I don't just depend on the internals, though I take a bath in it. I put it on topically in the problem areas that I have. And that's really changed her mind about it, and then changed her mind as she works with other patients. So I think patients have power in this as well.
I just want to follow that up with one. What's very interesting, as you know, as you were discussing, was that you have a history with alcohol and addiction, right? And so she is a physician who is giving you addictive opiates, right? Which makes it very interesting, right? Why would a physician give someone who has addiction problems something they can get addicted to? This is part of the problem with the whole opiate crisis, because they don't really know where to go with it. They figure gabapentin's safer. That's got side effects as a level 1, but you know, I think a lot of physicians just, you know, they need to educate themselves, as James was saying. They don't learn about the endocannabinoid system. I'm a chiropractor. We don't learn about that. I mean, no one really learns about it because it's kind of new. I mean, Raphael Metscholam, you know, you're talking in the 80s that, you know, this started really growing and getting popular, and it's really, you know, full head of steam now. But anyone who's been in the field for any period of time is not going to know anything about this. So, you know, when you're going to your doctor and saying, I'm going to do CBD, oh, there's no proof, I don't see it work. I mean, what do you think? The tramadol or and that's a light addict. It's not as bad as some of the other opiates, obviously. But I mean, how can you even question as a physician in that regard? You know, I have addiction problems. You're giving me something I could get addicted to. Why don't I try something that I know is 100% non-addictive, addicting? It's very interesting, and that's what we're really looking at now. And this really is an education process. The great thing, and we have like neurologists that I work with and pain managements with our products and whatnot. But in pain clinics is, if you can get a hold of the physicians and speak with them, a lot of them really do want to find better ways. Physicians are doctors. They want to help people. But if they don't know about something, what's usually first instinct with all of us? If we don't know something, we're a little bit afraid of it, right? We kind of go with what we know works and what we're comfortable with. So sometimes it's just opening up eyes, and it makes a really, really big deal, and it really makes a difference. So it's a great story that you tell.
And you know, and moreover than that, what for, you know, if that clinician says I don't know, then that's a good thing. What's more likely to happen is that, you know, most clinicians say, if I don't know about it, then it must be bad. So, no, you know, you shouldn't use that because of X, Y, and Z, no matter how illegitimate X, Y, and Z may be. But it's because of their lack of knowledge, their lack of understanding, that they're going to say, no, it's bad for you. That's a bad thing to do. And how do you change that? You know, it's very unfortunate that, you know, I think actually nowadays there is time being spent on the endocannabinoid system in basic medical pharmacology, but from a clinical side of things, most medical schools haven't. You know, they're only at the very beginnings of being able to embrace that. So young doctors coming out of their training have only the barest experience with it, and that's really where it needs to change. And I think that as it becomes more common and becomes more popular, we will see that happening. We will see minds opening. But like I said in my talk a little earlier, it's one mind at a time, and that's frustrating when we all know the power of what this can do.
So, is this one on? Yeah, there we go. So we have started education programs. I'm a part of a group doing a medical professionals education certification program. We've actually gone to the boards of nursing in states. We're going to the National Board of Nursing on the federal level. But as he said, doctors are evidence-based clinical guys. And until they can see the studies that can show them that this works, they don't necessarily want to buy into it. Most of the investors in my company are all healthcare people. They're all physicians. They, they support cannabinoid therapeutics. But even some of them don't quite understand what we're doing. So like when I'm having a board meeting with them and we're talking about stuff and they're like, wow, that does that? I'm like, how are you not even educated about this? You invested in a cannabis company. Cannabinoid therapeutics should be like the forefront of where you're going. And he's like, well, show me the clinical trial stuff. So now he probably hates that because I bombard him with studies and research all the time now. But it really is about one person at a time. And I think that we're getting there. I love the program at Jefferson is new. It came out of their, Pennsylvania's new medical cannabis and the research, and Jefferson has been proactive about bringing the research and the science. And unfortunately, doctors only listen to other doctors. And so until they have another doctor teaching them about cannabinoids, they're going to be a little bit shy about it. And then they're going to say, show me the evidence, show me the research, show me the clinical trials. So all of that takes time. Trust me, as someone who's been growing weed in this industry for 20 years, beating it against people's heads, you have to pay attention to this. They're finally catching on. And we'll get there. It takes time. And the more physicians and nurses we have talking to other physicians and nurses, the better off we'll be.
What's the most sought after clinical trials that they're looking for to see evidence from? Like from a university standpoint, if you're going to be getting, finding a grant or, okay, now this really needs to be a priority on studies.
So I'll jump on a couple of those real quick. So number one, NIH is really interested in opiate addiction medicine right now. And so there are grants out there for study projects like that. But, one of the problems with cannabis therapeutics is you've got 140 cannabinoids. We don't understand how they synergistically work together in the endocannabinoid system. And then on top of it, we know that THC over here works for prostate cancer and CBD over here works for pain. And there are so many variables when we're trying to study the medicine that unfortunately it's products like GW's Epidiolex that is an isolate-based CBD trash for the most part. We know that synergistically cannabinoid therapeutics works much better when you've got your terpenes involved and your flavonoids and your cannabinoids and all of those things working together. But FDA doesn't certify products like that. They certify 1 and 2 compound, maybe 3 compound kind of products because they don't want the variability. And so one of the things that we're trying to do in looking at studies is how do we get to some base products that we can have this very uniform study practice, this base to study from, and then be able to start modulating different cannabinoids or terpenes within that. So it's complex, but yes, the NIH is very supportive of addiction medicine right now and opiate reduction.
So would you recommend submitting a proposal for a full spectrum versus broad spectrum versus isolate benefits on pain?
We're working on that in our study as well.
Oh.
That we're trying to start to look at how do you have some of those base model formulas that actually can be uniform and consistent time and time again. Because as we know, if you're a farmer, I can have 20 plants of all the same strain in one room and they all have different cannabinoids in them.
I think what might be probably more interesting from a regulatory standpoint, or at least most clinicians are going to say it's a placebo-controlled trial. Those of us in this room, I want to know full spectrum versus broad spectrum versus isolate because I already know it works. I want to know which one works better. But what I think the basic science is going to be, show me that it works at all.
Right along. Yeah, right along with obviously what Dr. Fink said. And to go back to your question, because I mean, how many here are just consumer? Everyone here is on the business side, right? So how do you educate doctors? So what we do in our company when Bill set it up with me is I wrote a PowerPoint presentation, PDF'd it, and so our sales force goes and they will present with doctors and talk with them, get in with even nursing staff or whatever else, so someone that understands what's going on. The easiest way with physicians or chiros or anyone else to work with is go a topical route if you can. Give it to a patient who's in pain or is in feeling whatever, and let them go back to the doctor and say, hey, that stuff you gave me, or give them samples. This stuff really works. You know, it feels good. Then it kind of piques the interest of the doctor a little bit. It doesn't make them a convincer, right? It doesn't convince them right off the bat. It doesn't make them 100% in. But you're starting to get their own patient base who they know is not trying to lie to them because they've probably been dealing with these people, especially in pain. These people get passed from doctor to doctor to doctor, drug after drug. You know, you find something that actually helps them. They're like, oh, maybe they're not totally crazy. You know, things like that. And the same thing, you know, whether it's pain or mental health, because, you know, with pain comes mental health issues as well. And so even if you get any type of sample product or any type of basic, PowerPoint presentation on the endocannabinoid system, I educate, so I do that. And that's what we give to our sales force. And they have really great success going to physicians. And I don't know the physicians, so they didn't go in there and say, oh, you know, Dr. Madison, you know, whatever. No. We're in areas all over the place, but we're doing it by a very gentle education process that's very slow and steady. And it may take a couple meetings, but it's worth doing. Because, you know, you get it to the doctor, that's great on the business side, but that doctor's helping tons of people, and that's how the word gets out. So.
Companies that are making CBD products, I think most people understand, want to educate and empower consumers. If you have consumers who are using your product for pain-relieving ends, you can be the advocate, give them the education to convert their doctors. Turning your consumers into evangelists for your product and CBD is one of the most effective ways to sprinkle that information into as many channels as possible.
Feel free to plead the fifth on this, but those of us that would like to maybe gain more credibility, to have a platform to broaden education in our communities, what is your opinion about some of the certification programs that are being offered, with the caveat that we will be more respected and heard by the medical profession?
So I come from the aromatherapy industry, and in the aromatherapy industry we have, you can become a certified aromatherapist, a registered aromatherapist. There's all these levels you can get, and there's normally an outside certifying force that regulates that. So I have an aromatherapy school. My school curriculum had to go through the National Association of Holistic Aromatherapists to fit their standards so that all my students are at the same level as someone coming from another school. And so I'd like to see that in the industry. I don't see an outside certifying force. And like, to do my course, it's 100 hours. You know a little bit about aromatherapy when you're done with just the level 1 course. And some of the CBD things I'm seeing short numbers of hours for certification, and you just can't learn that much information in a handful of hours. Even as an aromatherapist, I've been one for 20 years. I have to do continuing ed every single year and prove that I'm continuing to grow in this field, to keep that certification. So I'd like to see that sort of thing happen in the hemp industry, where some outside source who isn't profiting off of the school is setting a standard. I also meet the international standard as well. So most NAHA is 50 hours, but I wanted the international standard, so mine's 100 hours, and I followed their things as well. So there just needs to be something like that, and is my feeling. But the other thing is that doctors still don't take us seriously. Now, I'm a registered aromatherapist, which means that I've taken a test where if I were someplace international, I could practice aromatherapy. I can't practice it here. But it still doesn't matter. Doctors aren't going to take that seriously, and then unless they have a bent towards natural therapies in general.
So I'll jump in and then.
Yeah, then I'll.
So cannabinoid therapeutics in general is what we need to be looking at. One, let's not separate cannabis from hemp. They are the same plant. One is a THC-rich plant, one is a CBD-rich plant, but it all works in the cannabinoid system, and all of the minor cannabinoids present in both cannabis and hemp are the same. So there is no difference there. Second, programs like Jefferson, where he's doing cannabinoid medicine, is, phenomenal, and we need to see more research organizations. As far as the certifications go, there are reputable groups out of there. So I'm part of the Cannabis Nurse Network. We're, as I said, Heather right now is working with state nursing boards and other organizations. So when you're looking at your certification programs, just make sure they're reputable. Right? Learn from other scientists who have done the work, who have spent the time understanding stuff. And so, one of the things with Heather, I was like, Heather, we have to have physicians speaking at these things now, because that's who physicians listen to. And no offense to the physicians, they just want to talk to one of their colleagues, one of their peers about real things. And so even from an educated nurse, until I have a rapport with that physician, they're not necessarily going to trust what I'm going to say. So, but when you're looking at those certification programs, look at stuff that is science-based, that has people who really know what they're talking about speaking at it or providing some of that education. But there are some good ones out there, and just kind of talk to me afterwards.
Before we get to your question, I love you bring up great points. She's talking about aromatherapy, and I'll bring massage therapists into this as like a little clinical gem for those of you who have products in your marketing or whatever else. When we deal with aromatherapy, what are the aromas? There's oils for plants. Right, which are essentially, most of them are terpenes, right? So if we have lavender smell, it's linalool. Citrus is going to be limonene, right? Pine, alpha-pinene, beta-pinene. Any type of cinnamon is going to be like, beta-crofulin or beta-carotene, however you want to say. So we're looking at all these things. Well, they're all working as an entourage effect with CBD. So if you're working with massage therapists or you're working with aromatherapy, CBD goes right in line with what they're doing, because essentially you can use those terpenes to probably almost push or aid the function of the CBD as well. So it's very interesting in that regard. Just to bring that up, because I never really thought about that. I formulated, and I'm thinking, all these different companies out there, whether it's doTERRA or was it Young Living or the other ones and stuff. People for thousands of years, and I have a lot of studies on this with all types of aromatherapy and what it does, and you get into frankincense and everything else. These all have medicinal properties. What if we combine them with something that we know is going to push, that's going to push the CBD even more? So it's a really neat area to get into, and those people are going to be very receptive. We're talking about opiates and addiction. And doctor. Yes, the doctors need to know, but, it works two ways. The doctors are treating patients. Sometimes we need to get to the doctor. Sometimes we need to get to the patients. We can work that angle either way. So if you don't have a lot of success on the physician side, gentle, education, having people try, go to their physicians. Those physicians get banged enough on CBD. Sooner or later, they're going to have to open up their eyes, or they'll want to, because they know it's actually helping their patients. And hey, maybe I don't need to prescribe as many drugs that have side effects. So I think there are a lot of ways of doing that.
Yeah, I have a question as far as working with management. So do you find that CBD prescriptions are cost prohibitive, especially when you're dealing with people on opiates? What is the starting dosage? Especially because when you're dealing with doctors, as far as healthcare, a lot of times everything is all covered by insurance. And considering the price per milligram of CBD, I think cost would be a huge factor that would make the physicians balk.
Well, I just reply to that, and this is something that we talked about in one of the panels yesterday. It's really tough when I can say to somebody, I think that this hemp oil is going to do wonderful things for you. Okay, well, how much is it? Well, this vial is $90. And they say, whoa, I can get a 30 Percocet for $5. Is that covered by my insurance? No, it's not covered by your insurance. Insurance isn't likely to cover it because they're not interested in they're interested in saving money. They're not interested in spending money, and that financial reality is important. There was a question yesterday about, well, given that a lot of this addiction is certainly common in the minority communities. How do we make such an expensive product more accessible in those communities where it really may make, statistically more of a difference, or at least, from a population-based standpoint? And it's a hard question. And like I said yesterday, I'm no economist, but as as this becomes more common and it becomes more popular, costs will go down. As delivery systems improve, we can deliver more product in more efficient ways, which means that it's going, or actually less product in more efficient ways. So therefore, I think that will also contribute to lowering costs. But very realistic concerns. You're right.
So I'll continue on that point because that is a big issue for people. Two things that we should be paying attention to. So the Safe Banking Act, which is before Congress right now, that will push the industry quickly and effectively. So one of the problems that we have with insurance companies is they can't touch it. Even if they are interested in participating, they can't touch it right now because it's still illegal for them to bank. So it's hard to get an insurance company to pay for a therapy that isn't even recognized by the federal government as effective and is still technically illegal until all of those people can operate on the same playing field with regards to the finances of it. So I'm encourage you to all reach out to your congresspeople and push them to that Safe Banking Act. It will help the industry in a plethora of ways. Some of them will be dangerous because it will allow these big pharmaceutical companies, it will allow these big insurance companies, these big banks to get involved. But we need some of that right now. We need some of that.
Can you
leverage.
describe what the Safe Banking Act is?
So basically, the Safe Banking Act is simply a piece of legislation that is going to allow, what do you know what the actually off the cuff SAFE? But basically, it is allowing a safe harbor that says, okay, the federal government doesn't necessarily recognize this product as illegal anymore. But at the same time, we recognize that there are all of these plethora of patchwork of businesses operating in this environment. We want to allow them to have access to banking services. And so one of the things that's prevented cannabis from really exploding is, and I say cannabis as a whole, CBD in general, because CBD is just starting to deal. Elevon was one of the last payment processing companies that was really accepting CBD transactions. There are a few now that are trying to fill in the gaps, but even CBD companies are having trouble banking now and payment processing. And so that makes it even more difficult for a consumer. So right now, for the most part, most of us operate in a cash-only environment. Safe banking will allow us to have bank accounts that will protect us from the federal government racketeering charges that are basically how they take down organized crime. And the safe banking will then allow the insurance companies to start insuring things. There was supposed to be crop insurance thrown into the 2018 Farm Bill. Well, that created a problem because the insurance companies were like, wait a minute, we have to insure this crop that we have to pay out on, but we can't even operate in this world. And so you're seeing this nexus of problems start to come together that it's forcing the government's hand into what we need to do. So that's one of the ways that we need to move, because if insurance companies can start covering the cost of these therapies, yes, it will make it more effective. But you're absolutely right. Right now, the physicians that I know that recommend it either have started a company to be able to subsidize some of their patients to be able to use CBD effectively, or their patients aren't buying it, or they're taking doses that aren't effective. I mean, we know that about 50 milligrams a day is a decent dose for endocannabinoid health. But 50 milligrams a day is a tincture bottle that someone's going to go through in 15 days that could cost them $100. It's not a comfortable alternative. So you're absolutely right.